Okay.
We've already met and talked about your interest in being a DMT volunteer. After a medical examination and a lengthy psychiatric interview, we decide you qualify to participate. You eat a light dinner the evening before and sleep fitfully. What will tomorrow be like? The next morning, you park your car at the University of New Mexico Hospital parking structure, walk across the bridge to the hospital itself, and take the elevator to the 5th floor, the Clinical Research Center. You walk up to the nurse's station and provide them with your DMT alias, one that you received in order to preserve your anonymity. After checking in, you walk down the shiny linoleum hallway to room 531, where the DMT nurse greets you and inquires about your welfare. She gives you the temperature monitor, which requires your going into the little bathroom and inserting a 4-inch wire through your anus into your rectum. Returning to the room, you take off your shoes and lie on the bed in your street clothes. The nurse places the black eye shades next to you on the bed. An IV is begun in one arm for drug administration and another in the other arm for blood drawing. The nurse places the blood pressure cuff on the arm next to her. I take a seat at the other side of the bed. Good morning, I say. Are you ready? Take as long as you need to collect yourself. Once you're ready, let me know. I will insert the needle into the IV of the arm near me and tell you when I will begin. The infusion of drug lasts for 30 seconds and then 15 seconds of sterile saline to flush the line. You may feel the drug going in, cold or tingly, slightly burning. Effects will begin within a few heartbeats. Take a deep breath into it as you feel the rush and let go. The rush is short, but it's important not to be thrown off balance. You'll quickly feel your consciousness separate from your body and think that you might have died. Don't worry, no one has. And if there are medical problems, a code team is always instantly available. There are 2 ways to deal with the fear of having died. One is to fight it with all of your strength, and I can tell you that won't work well. The other is to go along with it. Okay, I've died. Now what? Try to maintain awareness at all times. Effects peak within 2 to 5 minutes, and you'll start coming down at around 10. There are still things you can notice between 15 and 20 minutes. I know there will be a lot to talk about, but we can wait another 10 minutes, and I suggest trying to stay quiet until the half-hour point. If after 40 minutes or so you're still quiet, I will begin engaging you. Any questions? You reply, I think I'm good. We place the black shades over your eyes. You're already going inward, breathing slowly and deeply. You indicate your readiness. Take a deep breath, settle into the mattress. I lay my watch on the bed next to your arm and wait until the second hand hits 15 seconds. Okay, I'm starting the infusion. The cold DMT solution makes its way up your arm. Your heart beats stronger and more rapidly. Your body feels light and excited. A high-pitched sound begins ringing in your ears, and waves of kaleidoscopic images form and rush through your mind. You feel the drug. You say, I feel it. Here's the flush, I say. Okay, it's done. But by then, you are somewhere else and do not hear me.
All right, so thank you for that. That was definitely one of the more creative meditations that I think we've had this semester. That was pretty awesome. So I can go ahead and kind of introduce you, Dr. Strassman, and then we can move into the Q&A if that works for you. Okay, cool. So Uh, a native of Los Angeles, Rick Strassman obtained his undergraduate degree in biological sciences from Stanford University, his medical degree from Albert Einstein College of Medicine of Yeshiva University. He trained in general psychiatry at UC Davis in Sacramento and took a clinical psychopharmacology research fellowship at UC San Diego. Joining the faculty at the University of New Mexico School of Medicine in 1984, his clinical research with melatonin discovered its first known function in humans. Between 1990 and 1995, he performed the first new US clinical research with psychedelic drugs in a generation. His studies involved DMT and, to a lesser extent, psilocybin, and received federal and private funding. From 1995 until 2008, he practiced general psychiatry in community mental health and in the private sector. He has authored or co-authored nearly 50 peer-reviewed papers, has served as a guest editor and reviewer for numerous scientific journals, and consulted to various government, nonprofit, and for-profit entities. His book, DMT, The Spirit Molecule, which I have right here, has sold over 250,000 copies and has been translated into 12 languages and is the basis of a successful independent documentary that he co-produced. He is currently a clinical associate professor of psychiatry at the University of New Mexico School of Medicine. So welcome to our class, Dr. Strassman.
Well, thanks for having me. Pleasure being here. I love students.
Great. Yeah, so we have quite a few students actually that signed up in advance to prepare questions for you. So I want to give them an opportunity to ask their questions first before we kind of open the floor. So if anyone who has prepared questions wants to start us off, feel free.
I can go. So one of the strangest effects observed in the DMT experiences are the seemingly trans-dimensional entities, the aliens, giant insects, and the machine elves, which are claimed to be totally real by those who meet and communicate with them. Towards the end of the spirit molecule, you speculate on loose theories that multiple universes and dark matter could explain these experiences. How have these ideas aged, and what is the current path to researching psychedelics through that lens of metaphysical curiosity?
Well, that's a good question. Yeah, it's a pertinent question too, because I struggled to search, or I struggled, to locate, scientific models that could explain the consistent encounter with these, seemingly autonomous, sentient beings under DMT in the DMT world. Yeah, and I do speculate about parallel universes, dark matter, levels of objective reality that are normally invisible, which we might then be able to perceive with our mind-brain receiving capacity changed through the effects of DMT. Kind of like a telescope or a microscope for consciousness. The things are already there, or things are always there, but you need to use a new technology or some external technology to perceive them. And you could think of DMT as a technology. In fact, that's how one of our volunteers described it. It allowed access to different freestanding, objective, alternative levels of reality. I still think it's a viable model, but we're a long way from being able to experimentally refute or confirm the validity of that theory. So in the meantime, I've kind of broadened the notion of previously invisible to include things which are existent in our minds already, more or less conscious. And those things are, or at least, can be invisible if, they're unconscious, for example, or they're preconscious. And the medication, the psychedelic, will kind of amplify, shed some light, make clearer things which are completely internal to you, but which were also previously invisible. So mechanistic theories aside, the presence of the being seems to me to represent a symbolization or a visualization of certain kinds of information. So if that information is external to us, let's say in dark matter, or it's internal to us from the unconscious, it's our task to maximize communication, when we can, between between us and those things which were previously invisible, which are containing information. So how do we get the most out of what the images are trying to communicate to us, whether they're internally or externally generated? Metaphysics is a, topic, near and, dear to my heart. I wrote a book in 2014 about prophetic experience in the Hebrew Bible and the possible, relationship to DMT and other psychedelics. And the intellectual scaffolding of that endeavor were the works of the medieval Jewish philosophers, like Maimonides, for example, Sephardic Jew who moved to Egypt and was quite active there in the 1200s. So the Muslims and the Jews and the Christians at around that time were developing these quite sophisticated models of existence, spiritual existence, physical existence, psychological existence, which combined faith, scripture, text, with the modern Aristotelian, science of the day. And it was quite sophisticated. And it was the state of the art. It was, the cutting edge of intellectual endeavor. And so I think it's possible using those notions to resume studying spiritual experience with a combination, so to speak, of intuitive spiritual information from tradition, from philosophy, in combination with cutting edge science. So it would be a chance to start reconciling spirituality and empiricism, science and religion, or faith and reason, which is a relatively recent development. It only occurred in the 1500s, during the Enlightenment, and then spiritual experience became completely internalized with Freud and Jung. So I think it's the possible meeting point for science and spirituality to meet and discuss, which should be around the spiritual experience, the mystical experience, the prophetic state, those kinds of things. You could bring things in from the left and from the right, or from above and from below.
That was really fascinating. Thank you.
Does anyone else who signed up want to ask their question now?
There's one in the chat, Oliver.
Oh, yeah.
Is that from someone who signed up this week?
Okay, so yeah, so Rosanna says, sorry, I have to ask my question in the chat. Mic is not working well, but I guess I'm just curious to ask if there have been any studies assessing the effects of DMT to other psychedelics in regards to therapy. Also, given that there have been some issues seen when when using DMT for therapeutic uses or for therapeutic purposes, sorry, are researchers more inclined to use other psychedelics over DMT, or is more research still being conducted?
Yeah, that's a good, yeah. So those are some good questions. Well, most of the new, current research, psychotherapy research, has been using psilocybin and, to a lesser extent, LSD. So, these are studies in academic university, research units. Um, there's depression therapy, there's, substance abuse, there's OCD, there's smoking cessation, alcoholism, end of life despair, PTSD to some extent. All of those have been using psilocybin among the classical psychedelics. I think there was a psilocybin autism study. I'm not sure, but there's European studies with psilocybin as well. The Europeans are using a little more LSD, but both of those are long-acting drugs. The reason that people started using psilocybin is for a couple of reasons. One is it isn't as long-acting as LSD. You're kind of tacking an extra 4 hours onto an LSD experience, and it also doesn't have the notoriety of LSD. So those were a couple of both clinical and political reasons to choose psilocybin over LSD. And one of the reasons I chose DMT over either LSD or psilocybin was because of the notoriety issue, and the duration of action as well. Although in the case of DMT, it's over in an hour or like a half hour, really. Yeah, so there are no pure DMT studies yet for depression, although one just began at Yale, like this week. So there is one psychotherapy study with just pure DMT, and it just began. There are a lot of reports, therapeutic reports, anthropological, epidemiology, demographic studies of people who are in these ayahuasca using churches in Brazil in particular, some in the US. And those are field studies, as it were, surveys, as opposed to actually giving ayahuasca in order to treat particular conditions. Those the majority of ayahuasca studies indicating therapy are survey studies. You give questionnaires and interview members of ayahuasca using churches. But there is a small number and an increasing number of more clinical research kinds of studies using ayahuasca for anxiety and for depression. Those studies are coming out of Brazil. There is increasing interest in the therapeutic applications of DMT for both psychotherapy and other indications. That study at Yale using DMT for depression. There are all of these psychedelic startups kind of springing up around the market landscape. And, they're, looking at, different, formulations of DMT, different, routes of administration, like a tablet or a film or a patch or something like that. So those indications are probably mostly for depression, like, because if you give, DMT as an injection, it's pretty fast. It's kind of hair raising. So you would like a little slower onset of action. Well, yes. So there's a question there about ayahuasca and DMT. Yeah, there are two ingredients of ayahuasca, or there's two different plants. One contains DMT and one slows the metabolism down of DMT in the gut. So DMT becomes orally active because it isn't broken down in the gut as quickly. There's harmaline as well, which is an MAO inhibitor, which is also an antidepressant, but those kinds of treatments require a few weeks to start working. So the visionary ingredient of the experience is the DMT, and the kinds of neuronal changes which occur with DMT are quick, like within the space of an hour or two. So people are pointing to the increase of neuroplasticity that occurs within a short time period, the space of an hour, of the response to DMT, and also neurogenesis, which begins very quickly after DMT administration. So those two findings are being exploited or potentially exploited in two different directions. One of them is as an antidepressant treatment, because ketamine is a new antidepressant, works quite quickly within the space of an hour or two, which corresponds to the time course of the acute neuronal effects. And so the acute neuronal effects of ketamine are similar to those of DMT. So people are thinking that if DMT and ketamine both produce the same kinds of neuronal effects, then perhaps DMT will be an antidepressant in the same manner with the same time course. But our study, back in the 90s, looked at sub-psychedelic doses of DMT as well. Ones that just gave you like a little stimulatory effect, or a little mood elevation, or some calming effects. So there is a company in Canada that's repurposing DMT to help reduce stroke size in patients with stroke, and also to speed functional recovery. And they're going to use DMT at sub-psychedelic doses, which seem to be adequate for the neuronal response to occur. So you're giving a psychedelic dose, but one that is still neuronally active for recovery from stroke. They're also thinking about using this sub-psychedelic doses of DMT for traumatic brain injury, because of its ability to stimulate nerve growth and complexity between neurons, and the complexity of connections between neurons. So why isn't DMT used more often? Well, we may be seeing the tide shifting to shorter acting experiences like DMT, or ones that could be used with a sub-psychedelic dose. But I think up until now anyway, there are some pharmacokinetic issues with DMT. If you give it as an injection, it's very fast acting, and if you're not an experienced psychonaut, it can be kind of disorienting. The other is that a full dose of DMT is very weird. You encounter these beings that talk with you, they interact with you, they harm you, they hurt you, they help you, they hinder you, they confuse you. They're very strange looking. They're doing things to you, and you're kind of in amazement and you're shocked. So that isn't a typical psilocybin experience where they're playing playlists to help with your depression. DMT is completely different. It's completely out there. So I think if you're thinking about, using a full, dose of DMT, uh, you know, uh, as an injection, it can be a bit, too much. But I think, the idea of using, sub-psychedelic doses is, quite promising. So you'll be hearing a lot, more about the potential, therapeutic use of DMT in the upcoming year or two, maybe sooner.
I had a question related to that. So, like neurogenesis, could that ever cause a problem? Is neurogenesis, in effect, is that always a benefit to the patient, or could there be, complications or issues from it?
Yeah. Well, that's a great question, and it kind of hinges on lots of my soapbox rantings for the last few years. The straightforward response is if it's traumatic brain injury and CVAs, strokes, cerebrovascular accidents. I think that the benefit would of necessity outweigh the risks. And so far, there's animal studies which indicate smaller stroke size if you're combining the stroke with DMT, and functional recovery improves or occurs more quickly in rodents that are the experimental model. So they start to walk more quickly, or kind of start they begin to perform more normally. Once they're treated with DMT to speed up their rehab. So I think when it comes to neurological disease, the benefits outweigh the risks. With respect to using these compounds, including DMT, for benefit, for psychological benefit, to be like a better person or to improve depression. I think when it comes to treating psychological, well, it hinges on the set and the setting. So if you're treating depression by means of neurogenesis and neuroplasticity, you're steering the experiment into the direction of an antidepressant effect. You have a depressed person who's volunteering to participate in a study like this, and they want to get better, and they have faith in the experimental procedure to improve their depression, to make them feel better. They're educated about depression and psychedelics. When they're tripping, they're encouraged to respond to the experiences in certain antidepressant kinds of ways. And afterwards, the integration phase, they're kind of integrating their experiences in a way to minimize their depressive symptoms, increase their self-esteem, self-acceptance, courage in daily life. So you're steering the experience, which means that the rest of your brain is working in a beneficial direction. So I think if you're growing more nerve cells, if you're increasing the connectivity among them, I think what's going on around those more active neurons will be quite important in determining what goes on with them. So it's like you're stretching up a torn muscle. If your healthy muscle is being strengthened and being contracted and flexed in a particular direction, then the healing muscle fibers will follow suit. So I think the same thing may be going on with with neuronal recovery. So you want to steer the experiences in the direction that you're seeking. So if you want a spiritual experience, if you're a relatively healthy person and you want a spiritual experience, or you want to improve your creativity, then you need to do your homework. You need to be, doing those things, currently. You want to be, doing those, things already. So, when you do trip, you've, created like, well, like well, it's what's called a creode. It's uh, like a path, that's beginning, uh, to be worn, by traffic along a specific byway. So if you're already developing the creode, with creativity, with spirituality, then the psychedelics will work on that, and come up with new ideas, new insights, new inspirations. Um, you know, if on the other hand, you're in a confused, chaotic state, or you're a bad person and you want to become even worse. The increased neurogenesis, the increased neuroplasticity, those would be operating on what's already there in your mind brain complex anyway. So if you're already really confused, just chaotic, things will just be more that way. If you want to be a more bad person, you'll understand at a more deep manner, the ramifications of being a bad person. You'll become more convinced, or you'll develop new insights, those kinds of things. So you're basically working with the pre-existing material. So you want to kind of optimize that in the desired direction. It isn't neutral. It isn't like it's just brain food. You can grow weeds, as well as flowers.
So we have a question in the chat from Chloe, who signed up in advance. She said, you mentioned that individuals should be cautious with therapeutic DMT use, especially those with a familial history of psychosis. Is there any way to prevent these psychotic reactions, or are they kind of unpredictable? Also, are these reactions generalizable to most psychedelics?
Yeah. Well, you can't, guarantee that you'll prevent adverse effects from, DMT or other psychedelics. I think, DMT, well, one of the reasons I chose, DMT, well, there were, like a number of reasons, but another one is that it's quite short acting. And I knew that my studies would be stressful from the environment point of view. They'd be taking place on a research unit, busy university hospital. And I included in my grant application and my informed consent, documentation, if it's a bad trip, it's a short bad trip. It won't be for hours and hours and hours. Let's say you were on LSD and it went sideways. I mean, you could be screwed for like another 6 or 8 hours. With DMT, it might be horrible, but it's only horrible for 10 or 15 minutes at the most. One of our volunteers developed panic attacks after an overdose of DMT. We gave 2 people in the very beginning of the study too much DMT, and they just got confused, and we lowered, and as a result we lowered our high dose. But as a result of that overdose, one of our volunteers developed panic attacks. But they were transitory. They resolved in a few weeks, and he came back, completed the study, and did fine. A couple of our volunteers developed a recurrence of old depression. They had been depressed years ago, and briefly experienced recurrences of depression. One guy responded to getting back on an antidepressant. One guy responded to psychotherapy. And we screened people. We screened people very carefully. They all got a research, psychiatric interview that takes a couple of hours. I spoke to them, before they even took a step into the study. Physical exams, laboratory work. We did screen out people with a history of psychosis or a family history of psychosis. That seemed high risk. Depression, if it occurred years ago and they got a handle on what it was that got them depressed, and it was years behind them, we included some volunteers like that. But I think there were studies back in the 1950s, 1960s, giving psychedelics to schizophrenics, giving psychedelics to chronic psychotics. And those studies were for a couple of reasons. One was to compare the hallucinations, let's say, or the altered thinking that came from psychedelics with the altered mental experiences of psychosis. Were they similar, or were they different? Because that was a big area of interest when these compounds first came out. They were being called psychotomimetics. They produced a time limited facsimile of psychosis, and you could study psychosis temporarily or acutely drug induced psychosis. The other reason that psychedelics were given to schizophrenics, other psychotics, was to see if it could be helpful. Would they engage more? Would they pay more attention to their environment? Would their disordered thinking clear up? Would their hallucinations go away, or would they develop new insights? Would they engage in psychotherapy more? So those were quite interesting studies, and they were kind of crude. They aren't strong on informed consent, details, like that, but it didn't seem as if all those patients went crazy and went downhill. Some improved, some didn't respond, some got worse, but just temporarily, and they returned to their baseline quickly. Same with the positive responses as well. So it was a interesting field of research, quite quite inconclusive, and I think it would be of use under extremely carefully controlled settings. To revisit the relationship between psychosis, especially schizophrenia, and psychedelics.
Someone from the YouTube live stream had a question. They were wondering if you could speak about the extended state DMT research that Dr. Andrew Gallimore has proposed a model for.
Mm-hmm. Yeah, that's a very cool model. Well, toward the end of my DMT book, The Spirit Molecule, I propose a continuous infusion of DMT for a couple of reasons. One would be to characterize the state more carefully. If you're just smoking DMT or giving it as an injection, it's over, or you start, coming down, by the time you get your bearings, establishing communication with the beings, getting oriented, towards that space, which can take a couple of minutes, and you're kind of, shocked at, the transition, those kinds of things. So if you could extend that state, half hour or an hour, 2 hours, 6 hours, 8 hours, you'd be able to characterize the state, much more carefully. You can interact, with the beings. You can learn their language. You could examine the flora and, the fauna, the geology of the place. Take your little, hammer and you hammer on stuff or uh, your other equipment and, interact with the, contents of that state. You could also use it as a, therapeutic, tool. For example, if you have, somebody that's, working on an issue, let's say, with their parents, you can put them in a, medium state of intoxication, and, then, they would tell you, that they want to come down, and you'd speak with them, you would do therapy, and they would say, okay, I want to go up, to that, same level, or go, higher or, deeper. So you could titrate the experience, because once you turned off the drip, you come down in 5-10 minutes. I got the idea of the continuous infusion study because of the results of one of our experiments from the 90s, which demonstrated that closely spaced dosing of DMT didn't cause tolerance. So you give a big dose every half hour, 4 times in the morning, and the last dose will cause the same psychological response in strength as compared to to the first dose. And even though our volunteers were all healthy, everybody's got issues, and they were able to work through stuff over the course of the morning. The issue would come up in dose 1. They would get some more clarity in dose 2. They'd kind of bump up against a wall in dose 3, and then come to some resolution at dose 4. So I thought, well, gee, if there's no tolerance, you could just give it continuously. So a couple of years ago, Andrew Gallimore contacted me, and he said, that's a great idea. We should write a paper. So he would take it from the point of view of the pharmacology. What would the loading dose be? What's the metabolism, the half-life, what would the steady dose be? And my contribution to that paper was the clinical questions of characterizing the state more carefully and using it as a psychotherapeutic tool. So that paper came out 5 years ago, maybe 4 years ago. So now there's 3 groups which are interested in actually implementing a continuous infusion protocol. There's 1 group in Switzerland and 2 groups in England. I've been consulting with the British groups. I haven't been consulting with the Swiss group. But still, it's about to become a reality, which should be very, very interesting.
That's very exciting. Thank you for that response. So Ariana has a question, and it was mentioned in the lecture how the adverse effects of DMT should not be overlooked. And just to be mindful of the potential negative experiences, since there is an endocrine component to the DMT experience, are those with common thyroid dysregulation, such as hyper or hypothyroidism, included in the research studies or excluded? And does this make a difference in that regard?
Well, there's a couple of issues there. One is, thyroid health in the first place. So all of our volunteers were screened with a couple of, blood tests, for their thyroid function. And I think we found 1 person with abnormal thyroid function and excluded them. So you do want to be as, healthy as you can, before you trip, that's for sure. And if you've got, thyroid imbalance, you want to take care of that. The other is, are there effects of, psychedelics on, thyroid function? And, I can't remember if there were studies looking at that in the 60s. I don't think there are any currently looking at that question. We, uh, we looked at a slew of endocrine, parameters, including TSH, which is the pituitary hormone responsible for, regulating, thyroid production of thyroid hormones. And in response to, DMT, there, wasn't any alteration in the levels of TSH. I think we mentioned that in our first, paper, the one from the archives of general psychiatry, or if we didn't mention that there was no effect on TSH, there wasn't. So, and the responses, the hormone responses, that we looked at, were acute, like over the space of an hour. Most things return to, to baseline, within an hour. Growth hormone was, continuing to climb over the space of the hour, but I would think it, would have started resolving an hour after that or so. Melatonin didn't budge. Thyroid stimulating hormone didn't move. Most studies nowadays, if they're looking at the endocrine responses to psychedelics, they usually limit themselves to prolactin and cortisol. Be that as it may. What's more current nowadays is brain imaging, brain functional imaging, rather than the neuroendocrine responses. My mentor at UNM was a pediatric neuroendocrinologist, and so he taught me two things. One is dose response. You want to make certain it's what you're giving that's causing the response, and if there's a straight line correspondence between a small dose and a small response, medium dose and a medium response, a high dose and a high response, you're on pretty firm ground by proposing it's what you're giving them. It's the drug. And also back then receptorology, what receptors are involved, what subtypes of receptors are involved, those were being quantified through endocrine variables. And so we looked at beta, endorphin, ACTH, cortisol, prolactin, melatonin, growth hormone. We have some vasopressin data, but we never published it. Core temperature, pupillary diameter. We covered every possible base. So I guess that's some advice to future clinical researchers out there. Garner as much data as you can first time around when you're doing just phase 1 dose response study and normal volunteers. Characterize a number of different doses rather than needing to go back to the drawing board once the drugs are being used therapeutically or for other purposes. So adverse effects are real things. It's kind of a what's the word? It kind of bothers me in a way. That these are called challenging experiences, rather than calling them adverse effects. Challenging experiences, like if I slept poorly last night, that's a challenging experience. And so is permanent psychosis as a result of a bad LSD trip. That's a challenging experience too. So I think you need to be a bit more realistic not, sugarcoat adverse effects. There are a, range of adverse effects out there from, mild, medium, and severe. So I think, challenging effects is a little bit, gilding the lily, or, minimizing harm. You need to call a spade a spade. If you give a drug and something untoward takes place, I think that needs to be made, public. You need to talk about it. You need to, raise the discussion. Like, okay, I gave DMT, and everybody's developed headaches, and that's a problem. Yeah, it should be published if that were the case. Case in point is that a number of years ago, a study came out of Johns Hopkins, giving psilocybin to the terminally ill, and you know, the responses were great. Mystical experience questionnaires were high. Those high scores indicating a mystical experience were, correlated with improved mood, less depression, less painkiller use, all kinds of, positive things, which were true and great. But if you look at the body of the paper, under adverse effects, it says there were no adverse effects, to psilocybin in this study, and that's it. But if you look in the supplemental material to that paper, which is only online, the very last paragraph of the supplemental material speaks about a suicide that occurred in that study. And it occurred with a low dose of psilocybin, a completely inactive dose, pretty much. But still, within 11 days after that, person's experience, she killed herself. And why is that? And I think it's a result of the model that was being used. Like, if the goal of the model is to have a spiritual or a mystical experience, and if you don't, you missed the goal. And I think, although you don't really know, but I think this may have been what took place in that study, is that she got a super low dose. There was no way that she was going to be having a mystical experience, and figured, what the heck, that was a waste of time. I'm no better off, I'm even worse off, and what's the point? And I think, strictly speaking, that was not a side effect of the psilocybin. There's, obviously not, because it was, it was a completely inactive dose. But I think it was an adverse effect of the model. And I think that's a very important thing to discuss in, the literature, in the media, is, it's a very complicated situation. You're giving a drug, you're preparing them, you've got this, set in the setting, so, this will, this, was a suicide in our psilocybin study. And, what went wrong? Rather than saying it wasn't an effect of the psilocybin, so it's a lot more, complicated. And it's important to, shine a light on those kinds of problems, because, there are going to be increasing numbers of adverse effects to psychedelics as they're increasingly available, either, medically, medically, or, recreationally, spiritually. And, some smart, journalist is going to be, digging around and, discover, that case of, suicide in a psilocybin study. And they'll say, why wasn't this, more well publicized? Why didn't you guys, talk about it at all? So I think if we're going to, not repeat the mistakes of yesteryear, looking at these, substances within, the larger community, we need to learn from those mistakes. We need to be honest, straightforward, transparent, disclosing, all those kinds of things.
Is there anything that you would like to leave us with at this point, seeing as we're pretty much at time?
Well, yeah, what should I leave you guys with? Well, keep an open mind. I think it's human nature to prematurely close discussion of complicated things. So if there's anything we should learn from the psychedelic experience, it's, to keep an open mind. We might be wrong, no matter how firmly convinced we are that we understand what these drugs are, what they do, how they work. I think they're quite interesting that way.
Thank you so much. This has been a real pleasure. Thank you for coming out today and being part of our class. It was really cool to learn from you.
Well, thanks again for the invitation. My pleasure.
Yeah.
Good luck.
Thanks.
Thank you.
Hey, Rick, we have 2 more questions from the live stream. If you wanted to stick around and answer them, totally no pressure either way.
Sure.
Okay.
Mm-hmm. Yeah.
So one of them, in response to what you were saying earlier, you talked about decoding the language and engaging in communication with entities inside the DMT space. Does this imply intelligence outside of subjective experience?
Yeah, I just don't know. And yeah, it, kind of, returns to the point I was making earlier on about, the entities or, the beings, or even, just the information contained in the state itself, even if it isn't, kind of discretely, condensed or localized into a, recognizable being. There is, there is information that's contained in that state. And whether it resides within us, in our unconscious or preconscious, or if it exists someplace outside of us, like in dark matter or some Proxima star system. The important thing, at least practically, is to get as much information as we can from the images which are presented to us. So in a way, it's like I'm interpreting, dream imagery. You want, to remember as much as you can. You want to have some, tools, that you apply, to the visionary state in order to enhance communication, to understand what's, being exchanged, and, then to think about it afterwards. And if possible, are there references that you can turn to help explain things that may not have been completely clear at the time. So yeah, I think we're a long way off from determining the location of that information, but that doesn't relieve us of the responsibility of getting as much information as we can, from whatever it is that is presented to us.
Yeah, that makes a lot of sense. And then one other one was, do you have any thoughts or opinions on the stoned ape theory?
The stoned ape theory. Well, yeah, Terence McKenna, suggested, that, monkeys tripped and they would, visualize, sounds, coming out of their mouths. And it helped their vision and those kinds of things. But the most, far-reaching is, the discovery of being able to communicate, verbally, through, visualization of language. Yeah, so, it's a cool theory. I knew Terence. He, sat for my first DMT experience. Quite an inspiration. Super guy. Yeah, but anthropologically, I can't, really, comment on the strength of that, theory.
Cool. Thank you so much.
Okay, you're welcome. Okay, see you later.
Thank you, Rick.
Thanks. Okay, shall I leave?
Yeah, you can stick
Yeah.
around if you want to, but you're